Even though I think these guys probably know you. So we're delighted to have Dr. Rebecca Ivers here all the way from Australia today. She's a professor in the Department of Epidemiology, is that right?
No, in public health.
At the University of Sydney, and she's going to be talking to us about the very timely and important topic of the burden of injury.
Thank you. Okay, so what I'm going to do is just talk about, I'm going to go over the burden of injury, but I'm going to give you a bit of a history on the background to Aboriginal people in Australia as well, and I'll talk a little bit about our research. I'm sorry if everyone's heard all that, but it's going to be right at the end. So what I do want to do, and we always do this in Australia, is that we always acknowledge the traditional custodians of the land, and obviously that's not Aboriginal people here, but I would like to acknowledge the traditional owners of the land here that we meet, and to elders past and present. This is something that in Australia has become a very symbolic kind of start to meetings now. And this top flag on the right is the Aboriginal flag, and the bottom flag is the flag of Torres Strait Islanders. And so when we talk about Indigenous people in Australia, we're referring to both Aboriginal people, which are the main group of Indigenous people in Australia, and Torres Strait Islanders who sort of live right up in the Torres Strait Islands, which is I'll show you a map later on, which is off the coast of Queensland. So there's been a lot of debate about naming, and we tend not to refer to people as Indigenous peoples, but rather do the sort of full Aboriginal and Torres Strait Islanders in sort of respect of both of those different groups of people that were the original owners of Australia. So this is what I'll be talking about. Just to give you a bit of background to Aboriginal people in Australia, they have been living in Australia for a very long time, at least 50,000 years, possibly 120,000 years, probably emigrating from Asia at that time. So living very happily in Australia up until 1770, when James Cook arrived and charted the east coast and claimed Australia for Britain. The colonisation of Australia was, as it was in many other countries, which sort of involved lots of massacres and decimation of the population. And the fact that this had occurred was made worse in 1835 by the doctrine of terra nullius, which basically was issued, this decree was issued, and that basically stated that no one had lived here before. So Aboriginal, there was no inhabitants. The land was uninhabited when the British Empire arrived, and therefore they were able to sort of, they were the British were the owners of the land. So that was something that people clearly struggled with for a very long time, and that wasn't overturned until, in fact, about 1992, when native title to land and waters was awarded with by the High Court in Australia. So an incredibly long time to get to that point. Aboriginal people weren't allowed to vote until 1962, and we had a landmark referendum in 1967 which permitted counting of Aboriginal people in the census. So 1967 is fairly recent. Up until that point, they were listed as flora or fauna. And so really, Australia's had a very long and torturous history with Aboriginal people, and not a very happy or gracious one by any stretch of the imagination. So Aboriginal people from the very beginning were forced from their lands via violent means, decimated by smallpox and other diseases that the colonisers brought. There were multiple massacres, far too many to list, but a really shameful period in Australia's history, and one that we really struggle with. We have a lot of debate in Australia about how much Aboriginal history is actually taught at schools, and I think to this day we probably don't, people probably don't understand as much as they should about what actually happened in those early days. Over the years, and really went from 1870 through to sort of fairly recently, Aboriginal people were pushed off their lands and sent to camps, missions and domestic training camps. So across the whole country, as people moved into, the colonisers moved into various areas, the Aboriginal people were pushed off their lands, massacred, killed, and then in later years came into various missions, cattle stations. Much of Australia was farmed, and so Aboriginal people were sort of treated more or less as slaves on farms, working for very small salaries. And again, something that wasn't really redressed until quite recently. We have multiple stolen generations, children who were forcibly removed from families, and this is part of our assimilation policy, which was that trying to assimilate the Aboriginal Australians into the white community to ensure that they would be bred out. And that was actually a formal policy of the government. So children, particularly children who had some kind of white ancestry, were forcibly removed from their families and taken away to domestic institutions and training camps and sort of sent to work for families or adopted out in the hope that they would become white, and, you know, Aboriginal people would be gradually bred out. And that's really up until 1969. I myself have got people who are my age who were part of the stolen generations, who, you know, and clearly that's, again, something that we're still struggling with, and still there are families and incredible networks that are set up in order to actually bring people back together with the families that they were taken away from. Aboriginal people have got very strong and diverse cultures nonetheless. We've maintained there's a very strong culture in Aboriginal people today. They have strong extended family relationships, which are the core of their kinship systems. This really defines where a person fits into the community. So it binds people together in relationships of sharing and obligation. So often someone will say that they've got 3 or 4 mothers. They'll have a range of different people that they have special relationships with in the community. And it defines roles and responsibilities for raising and educating children and financial support. So often people will be supporting a range of other people within a community. It's hard to define because it varies from community to community. Aboriginal and Torres Strait Islander peoples are incredibly diverse, and that reflects the traditional and geographical variations across the country, but also different experiences since 1788. So you'll find now that we have the highest population of Aboriginal people living in Sydney and in southwestern Sydney and areas of Queensland. And they're people who have often been taken away from their families and moved on from their lands many decades before, so have actually rather limited connection with their tribal lands and their Aboriginal communities, even though they still hold quite strong connections to those lands. In comparison, there are many people that are still living in quite remote communities and have very strong kinship systems still in place and have got very strong relationships with the land and still will go out hunting and sort of living a sort of semi-traditional lifestyle. So we have a lot of diversity now across the whole country, and that does have really important implications for health status, because when you're actually looking at addressing the health status of Aboriginal people, you've got an incredibly diverse culture from, you know, very middle class, urban dwelling Aboriginal people to people living in very remote, semi-traditional lifestyles. So, you know, it's very challenging, to say the least. This is just a picture of Aboriginal Australia and all the different tribal areas, and just showing you the incredible diversity of language and culture. So these are all different language groups across the country, and you can see that there's many of those languages are starting to die out now, but there's still at least 150 languages still in use across the country. You'll often find that in remote areas that there are people that will speak multiple languages, and many of those people don't have English as a first language. English may still be their second, third or fourth language that people grow up. There's a lot of discussion about whether, particularly in more remote areas, about whether education should be bilingual. There's been a bit of a move in the Northern Territory to having education, children are taught in their Aboriginal language and taught English as a second language. We'll be going backwards and forwards on that for a long time, but often we will have to have English-speaking language people who speak the Aboriginal languages as teaching assistants in classrooms to aid education, because children don't have English as a first language. And I've been in some of those classrooms with road safety education, and it's incredible. I mean, it's really interesting watching it, but it's something that I just didn't countenance was actually happening within the Australia that I was living in. So, you know, we do have an incredible amount of diversity. This is the Torres Strait right up here on the right-hand side up near Cape York. So this is the Torres Strait Islanders up here. And so parts of Australia are incredibly remote. This is just to give you a sense. So this is from, I think this is this area down around here, just to give you some sense of the breakdown. You can see that this is the Arrernte, this is Alice Springs here, so this is the centre of Australia, somewhere around here, I think, and this just shows you, you know, how many different language groups there actually are around here, but they're phenomenal. And often the languages are really different from each other. So people who speak one language have got absolutely no understanding whatsoever of other languages. Australia is also an incredibly large place as well, remembering it sort of sits pretty neatly across the whole US. So, you know, you think this is we've got a very small population, 24 million spread over that whole area. Large stretches where there's no one. So just thinking about where Aboriginal people live, a higher proportion of Aboriginal people live in remote areas. So you can see here, this is the Indigenous population, the darker one. So very remote areas. A higher proportion of the Aboriginal population live in very remote areas compared to non-Aboriginal people, and a lower proportion in major cities. However, most Aboriginal people actually live in urban areas. A higher proportion than non-Aboriginal people live in remote areas. You can see New South Wales, which is the eastern state that I live in, 150,000 people. There's only about 550,000 Aboriginal and Torres Strait Islander people across the whole country. They comprise about 2.5% of our total population, but they're really spread out. So 30% live in New South Wales, and another 30% live in Queensland, 15% in Western Australia and Northern Territory, and a much lower proportion in the other states and territories. But you can see over here, in New South Wales, Aboriginal people are only 2.5% of the population, a little bit more in Queensland, but in Northern Territory, they're actually 31% of the population. So Northern Territory being this part of the country up here. So the 30% of the population there are Aboriginal people. This is just showing you where Aboriginal people live. So the bigger circles are where the greater populations are. So you can see around Sydney and all along the eastern seaboard, and that's really where every other Australian likes to live as well, is along the eastern seaboard, because that's where the climate's nice. And traditionally that's where most Aboriginal people actually live, because there was, fertile land and good hunting and fishing. So many Aboriginal people all the way along the coast, and then up in Darwin and Arnhem Land. Arnhem Land is all Aboriginal land, and you can see this yellow land is Indigenous held land. So when native title was brought back into place, then a lot of Aboriginal land went back to Aboriginal people. Unfortunately, most of the land that's been handed over to Aboriginal people, they have actually been able to claim back. To claim Aboriginal land, you have to be able to show a consistent relationship with the land over many decades. You've got to be able to say that this is our land, this is our dreaming, this is where we were brought up. Unfortunately, because of colonisation, people have actually lost that connection with the land, and then they're unable to actually document their relationship, because Aboriginal history is often an oral history, so there isn't anything actually proving it unless there's that continual connection. So, I mean, that's one tragedy. Most of this land here is very arid, horrible farmland that no one else wants. So, and Aboriginal people haven't been removed from that land. So that's where the population mainly lives. But you can see that there's all these little remote spots all over the country, all the way through the Northern Territory, a bit in South Australia and Western Australia, up in all these really very remote areas. So, the biggest towns here are, say, Alice Springs and Darwin. There's a few bigger towns, 2 towns here, but everything else is just small remote communities. So again, when you're thinking about access to health services, it's very challenging to provide very high quality health services to a population where there's very small numbers of people spread and dispersed all the way across the whole country. So the Aboriginal population is quite young. These slides are from the Australian Indigenous Health Infonet. Rather than going and repeating all of this in my own slides, I'm using their ones, which are provided for this purpose. The Aboriginal population is much younger than the rest of the population. You can see from the pyramid here, much higher proportion of people in the younger age groups. When we think about infant mortality, again, so health status is poor across the board. It is improving, but in general, it is poor. Infant mortality rate is high. The rate for Indigenous infants was highest in the Northern Territory. So again, when we're seeing these large clusters of Aboriginal people, the health status is far worse. And we have had significant declines in infant mortality rates, and for non-Indigenous infants as well as Aboriginal ones across WA, South Australia and the Northern Territory, but there are still very high rates. So the leading causes of death, cardiovascular disease and cancers and injury. The mortality rates, though, are still very high. Maternal mortality rates nearly 3 times higher for Aboriginal women compared to the rest of the population. Age standardised death rates are high. So the Indigenous rate, the rate ratios over here on the right-hand side, and you can see that in every state for which we have data, they're higher than the rest of the population and highest in WA and the Northern Territory. And again, that's basically characterised by a relatively, large number of Aboriginal people, but a lot of their population is spread in very remote communities rather than sort of in the urban centres. Expectation of life at birth. For the Australian population, it's 82.6, and you can see for females 78.7 for males, and for Indigenous people it's about 10 years less than that. It's actually probably a little bit higher than that at the moment, so the gap is actually closing, and it's probably, there was a recent report which said that it was back down to 7 or 8 years gap, but it's still far too much. But you can see again that life expectancy is a lot shorter for males than for females, and particularly bad in the Northern Territory. The Northern Territory also has the distinction of having the highest fatal road crash rate for every other state as well for the whole population. So I've been doing a lot of work with the Northern Territory government, but the fatal crash rate for everyone in the Northern Territory is 19 deaths per 100,000. For the rest of Australia, it's about 6 deaths per 100,000, so they're kind of really not doing well. If you're an Aboriginal man living in a remote part of the Northern Territory, your fatal road crash rate is something like 30 deaths per 100,000, which is it's worse than death rates in sub-Saharan Africa. So, you know, we are really struggling here. Indigenous hospitalisation rates are high. 4% of all hospitalisations were for Indigenous people, where they're 2.5% of the population, and basically the separation rate was 2.5 times higher than for everyone else. Main cause of hospitalisation is in fact for care involving dialysis, because we've got very high rates of kidney disease, and that's responsible for 44% of the hospital separations. Injury, though, is the next leading cause of hospitalisation, so this is excluding dialysis. And you can see that injury accounts for 13% of the hospital separations, and the rate ratio is 2 there. So you can see that injury is right up there. So Aboriginal people hospitalised for injury double the rate for other Australians. It depends on the type of injury. Assault is horrendous for women, particularly 36 times higher for Aboriginal women than for other women, and it varies by state and by year, but it's generally very high. And in injuries, the third most common cause of death amongst Aboriginal people, accounting for 14% of Indigenous deaths. Really high rates, obviously, and really unacceptable, considering most of it all of it is preventable. But it's very high for both intentional violence, suicide and assault, and unintentional injury, with transport but also falls. The problem that we have is that we've got really limited research. So very little documented on the prevalence, the nature and the cause of injury, or the impact of injury and disability on the community. We don't have a lot of descriptive data. We have problems we've got real limitations in data. And one of the reasons why is that we're not very good at collecting Indigenous status. We collect it in hospitalisation data, so when people go into hospital, they've asked the standard Indigenous question at point of arrival at hospital. It's not particularly well collected. Most of these things, if you go back to these, you'll see that the data we report on is from New South Wales, Victoria, Queensland, WA. I think South Australia's only just been recently brought on, but we're actually only reporting on 4 states up until quite recently, because the capture rate of Indigenous status was quite low, but the systems have been working on improving that. So we have data from hospitalisation. We also don't have Indigenous status in for injury, most key data collection. So it's not collected in police crash reports. In a couple of states, it is included in police crash reports, but only because police ask the person or investigate at the time of the crash whether a person's Aboriginal or not. So in the Northern Territory, a policeman, if they've got a fatal road crash or a crash, will say, tick the box to say whether that person's Aboriginal or not, but they do that by looking at them. So it's a visual observation, which is the worst way of collecting Indigenous status. Or by asking the person at the time of the crash. And, you know, I mean, I presume your police here are pretty similar to police in our country, and we have very, very good police, but we also have police that you would not want asking you about whether you're Aboriginal at the scene of a crash, because you could be pretty certain that the outcome of their investigation would be sort of somewhat linked to, you know, the answer that you give. So that's something that we have been sort of trying to move away from. New South Wales now collects Indigenous status in driver licensing data, so we are starting to get some sense of licensing, and because we can link that to crash data. So we'll get more data, but that's the only state that does that. We really don't have very many other ways of actually looking at Indigenous status apart from doing special studies and surveys. So, and we also have underreporting of injury, because Aboriginal people aren't necessarily getting the same treatment that the rest of the community is in terms of attending hospital. So this is the injury burden. Now, this data is quite old, and I've got different data sources that I'll be using, and some of the problem is that we don't have great reporting because of the limitations, so we're reliant on sort of various systems that we use. This is from the burden of injury study that Teo Voss had done, and basically, but it just shows you the main causes. It hasn't changed all that much in the last 10 years. Basically, you can see suicide, 28%, road traffic crashes, homicide and violence, falls, and then others. And that differs by males and females. Males are always overrepresented compared to females, but it does vary depending on the injury. This is some data, more recent data from New South Wales. In New South Wales, though, I'll just preface this by saying the rates in New South Wales are lower than the rest of the population by national data, because we don't have a really remote population, or people that live in remote areas of New South Wales are still much better service than people living in remote Queensland or Western Australia or all the other states which really do have, that very remote sort of outback kind of community. Majority of injury deaths in Aboriginal people are in males, and that's similar to the rest of the population, about 70%. We all know that males are overrepresented in injuries compared to females. The death rates are higher in Aboriginal men, so we have a rate ratio of about 1.67 for Aboriginal men, 1.46 in Aboriginal women compared to the rest of the population. Most of the deaths, or at least greater than 50% of the deaths, are in people of working age, so people aged 25 to 44. So again, when you're thinking about the impact on the community, it's huge. An injury accounts for 12% of deaths in Aboriginal people versus 5% of deaths for the rest of the population. Now, I've got here really, this data is just showing you, this is for New South Wales, Aboriginal men. This is the rate per 100,000. I've just put the national rate in for things that I've been able to capture, so you can just see how much greater the national rate is. But this is the rate ratio for New South Wales men compared to the rest of the Aboriginal men compared to the rest of the New South Wales population. So you can see for men, self-harm, transport, poisoning, and interpersonal violence is high, but with high rate ratios. So, 4.15 for interpersonal violence for Aboriginal men compared to the rest of the population. And a lot of that is alcohol related. But you can see that the national rates are sort of nearly almost double. So for self-harm, transport and interpersonal violence, the same kind of, they're very high, but much, much higher for national. For women, the key issues, again, poisoning, transport, self-harm, interpersonal violence and falls. And you can see the rate ratios are particularly higher for poisoning and for interpersonal violence. But you can see here the national rates are, again, somewhat higher. They're not nearly as high as for the men. In the national data, injury from fire is also very high, so a rate ratio of about 12. And that's basically because in the national data we get people living in remote areas. For fire-related and burns, basically, a lot of that is in children, and most of that is in the mainstream communities from scalds, from kids tipping cups of hot water over them. For Aboriginal children, it's actually, and for adults, there's a lot of campfire-related injuries. So people living out in more remote areas and kids are getting injured in campfire. So there's many more fire-related injuries and higher rates of poisoning again. So that's where it differs most. So coming back down to injury-related hospitalisations in New South Wales, falls, high interpersonal violence, self-harm and transport, and then a bit of cutting and piercing for males. But again, that's just the proportion. You can see that they're very, again, falls is a really important cause of hospitalisation. Some of that, the highest rates are actually in old people, so old people slips and trips and things like that, and we're actually starting to do some work in that area because it's an emerging area of focus. And the Aboriginal community is now coming out and saying, we work with you, peak Aboriginal community-controlled health service organisation. So Aboriginal people have there's community-controlled health services that deliver primary health care, and there's peak bodies that represent all of these organisations. And they've been saying to us that all their services are coming forward now and saying ageing and healthy ageing has become more of a priority for the people in their communities. So we're starting to do work around falls and healthy ageing. But we do have high rates of falls in children as well. So, and again, they're falls from bunks and stairs and beds and things like that. Injury, 20% of injury-related hospitalisations in Aboriginal people were attributable to alcohol compared to 15% in non-Aboriginal people. And the rate ratios for injury increase by remoteness, especially for women. So they are, compared to the rest of the community, that is. So 1.26 in metropolitan areas, but 1.73 for remote and very remote areas. So injury rates go up for everyone with remoteness, but they go up more for Aboriginal people compared to the rest of the community. Alcohol is an issue, and it depends on the type of injury. So for violence and assault injury, alcohol is up there with sort of 50%. For things like pedestrian injury, so for road injury in remote areas, about 90% of pedestrian-related fatalities in Aboriginal people have got alcohol involved, and that generally relates to people who are absolutely inebriated and drinking outside of watering holes, so people drinking out on the street, wandering onto the road and being run over. When we look at interpersonal violence, again, age standardised rates are very high. For males, 4 times higher, and females 13 times higher. And again, as I said before, that can be even higher than that, depending on where you are. And most of these occur in urban and regional areas, but the rates increase with remoteness, just reflecting where people are living. Most is due to assault by bodily force. So basically and a lot of this is domestic violence related. We've just had this horrendous incident in the last day where Bess Price, who is one of our Aboriginal members of the Legislative Assembly in the Northern Territory, who's a traditional Aboriginal woman from Australia, in the Katherine region, her sister was just stabbed to death in a sort of violent, and it's reported to be alcohol-related incident in a town camp outside Katherine last night or the night before. So again, and Bess Price is a very strong advocate against violence in Aboriginal communities, and will often speak about how she's actually managed to get out of it and go into politics and represent her people, but it's really just shows you that there's not very much separation from someone like Bess and the terrible incidents that happen. And so 40% of violence-related hospitalisations involve women compared to 19% in non-Aboriginal people. So a very high proportion of sort of assaults involve women. And again, as I said, most of it's domestic violence, 50% involving alcohol. Again, just another anecdote is when I was actually working in the Northern Territory in the Katherine region 2 weeks ago, and I got up to go for an early morning walk, and people come into town. We've had a federal government intervention, which has been very controversial, but what that's meant is there's a lot of many more dry communities that have been imposed, and that now means that many more people are actually coming into towns to drink, and town camps where people come into to sort of access services, but people will often get stuck in town and living in town camps or living out on the streets and camping out on the streets and drinking very heavily. But there's just broken glass everywhere, everywhere that you walk. And, at night time it's become much more dangerous to actually walk around because there's so many people, there's so much more violence in the community. And it's really, and it's not dissimilar to what actually happens in some of the Native American communities here and in Canada, but it's very difficult to address these issues. Social and emotional wellbeing, obviously with very high rates of suicide, social and emotional wellbeing is critical. So, and these come from some of the big population-based surveys that have been done in Australia. So nearly 80% of Indigenous adults experienced at least one significant stressor, compared to 62% in the total population. Very high levels of psychological distress. And people are also hospitalised for mental and behavioural disorders at double the rate for non-Aboriginal people. And the death rate for intentional self-harm was 2.5 times the rate for non-Aboriginal people. These are just some of the stresses that are reported, and you can see this is a proportion of Aboriginal people that report them compared to the proportion of the total population where it's known. And you can see for things like death of a family member, serious illness or disability, that's pretty similar. Higher for not being able to get a job. Alcohol-related problems, it's higher, and mental illness, and then trouble with the police. And again, many people report, being stigmatised and being picked up by the police. Very high unemployment rates, particularly in remote communities. And we've had some experiences with our own staff in Sydney and police harassment, where they'll be just going about their ordinary business and they'll just be picked up and questioned very heavily by the police just for sort of going about their usual business because they're in, a suburb with a high proportion of Aboriginal people, and because they look Aboriginal and therefore they must be up to trouble. So, and, having people coming and telling us the stories and the things that actually occur to them is, you hear this on a daily basis. The age standardised death rates for intentional self-harm are also very high, and you can see the rate ratios are particularly high in WA. We're in Western Australia. Again, this is just by age group, and you can see that for Indigenous, and the rate ratio again is high. Females 15 to 24, 25 to 34, and 35 to 44. So, and this is for self-harm remembering. So females are a lot higher than males. Male rates are a lot higher for completed suicide than they are for females, which is a pattern that I think we're all familiar with. Falls the biggest contributor to injury hospitalisation. So as I said, highest rates are those amongst older people, but large proportion are in the 5 to 14 year age group, and mostly it falls on the same level. But for children, a lot of falls involving playground equipment for younger children. This is just showing you the fall rates, and the fall rates have been gradually increasing over the years for both. So males, this blue line is Aboriginal males, and this is for Aboriginal females. Again, though, it's not entirely clear whether that's a true increase or whether it's because we've got better reporting, because we are getting better reporting of Aboriginal people in the population as well. So that may be reflected in that, but you can certainly see that there has been an increase. Transport injuries, death rates are high across all age groups. Basically, we have about double the rate of fatal transport-related crashes for Aboriginal people, and about a 30% increase in serious injuries. Again, higher for males and females, higher in rural and remote areas, more single vehicle crashes and pedestrian and passenger crashes related to injury, high proportion involving alcohol. So this is just showing you the proportions, and again, this is the most recent transport data that we've got up to 2010. These are Indigenous males, the dark black line, and other Australian males here. So you can see males are absolutely overrepresented. Basically, once kids start getting mobile out on bikes and then out into cars, you can see those rates go up quite dramatically, and it's across the whole life course. Likewise for Indigenous females, but you can see that it sort of starts at a later age when women are starting to be more over-involved. And these are serious injuries that basically for transport related, that obviously goes up, very early. And that's reflecting kids as pedestrians and on bicycles and things like that as they're getting out and about as well. And that starts to drop off as well, but it's still greatly overrepresented. Though you can see the other, for Aboriginal men, it's quite similar to the rest of the population. Increases with remoteness again for Aboriginal people. This is for transport-related injury. You can see that there are, for hospital admissions, they're high, but very remote. It's actually high for non-Indigenous and pretty similar. For deaths, so dramatic increases for very remote areas compared to the rest of the community. By road users, if you look at hospital admissions, you can see that the biggest for Aboriginal people are pedestrians, similar for car drivers, much higher for passengers, and that's reflected in the deaths as well, pedestrians, drivers and passengers. It's actually lower for motorcyclists, overrepresentation for pedal cyclists. And again, that's just reflecting, a lot of that's reflecting people's access to transport, more people out and about as pedestrians. A lot of those are these alcohol-related pedestrian injuries that I talked about before. It's actually, and it's hard sometimes to differentiate between these as transport injuries versus intentional self-harm or suicide, because what happens is that people will be very, very inebriated and they'll wander onto roadways, but sometimes it is intentional. And often, we've been through the coroner's records in the Northern Territory looking at the cause, and probably about 30% of those pedestrian deaths, the person has talked about suicide and has sort of, has got significant mental health issues before the time of their death. It's obviously very hard to actually document that. We have done some work recently with a linked data set where this is a multi-level modelling where we basically compared Aboriginal and non-Aboriginal serious injuries by the various road user types, but taking into account where they live, whether they're living in major cities through to very remote. And really what that's showing is that people are overrepresented. Once you take that into account, you can see that we do have overrepresentation in the regional to very remote for pedestrians, a little bit for cyclists, underrepresented for motorcyclists, but it's quite similar for small vehicles. The motorcycle underrepresentation is actually because we have very high numbers of non-Aboriginal people working on farms and riding trail bikes and motorcycles around, and actually it's probably linked to employment, people actually having access to employment where they do cattle mustering, so they do a lot of mustering by motorcycle in more remote areas.
What constitutes small vehicles? Is that like
cars?
Grain vehicles?
Just cars, no. Yeah. So what are the risk factors for road injury? So the reasons why they're high is lack of compliance with road rules. It's actually to do with the fact that more Aboriginal people live in a higher proportion are living in remote areas. So it's actually more of a factor of remoteness than Indigenous status. So less enforcement, lack of compliance with road rules because of that. Not wearing seatbelts. So, and again, very similar patterns to what you'll see in Indian reservations where people are driving around packed into to vans or trucks. We have Toyota trip carriers where you pack 15 people in. They've got a very high centre of gravity, very easy for them to roll, and then you have multiple deaths. That's very common. Lots of overcrowding and no restraint use. Poor infrastructure, long distance travelled on poor quality dirt roads, and reduced enforcement, and combined with livestock collisions because people are around in the bush where there's lots of cattle and wildlife, large kangaroos hopping around, and emus and camels. Older cars, poor quality cars, are less safety features, less maintenance and less access to cars, which leads to overcrowding. And then, of course, the issues to do with post-crash care, so lack of access to care. Lack of insurance probably doesn't make a difference in Australia because we've got a very good system of national health insurance, but certainly the lack of access to care is an issue, though again that's more related to the remoteness than anything else. Self-harm and poisoning, rate ratio of hospitalisations is very high, more in women, more deaths in men, so because they use more lethal means, and most of it's due to intentional poisoning, particularly in women. And then cutting and piercing. Now, obviously, it's hard to differentiate between self-harm and poisoning because we have so many intentional poisonings in the self-harm category, so these are all probably a little bit rubbery. High rates of poisoning in children, unintentional poisoning, it is double the rate in the general population, and mainly it's access to the benzodiazepines and antidepressants, and then the sort of paracetamol type drugs as well, but that's all unintentional. So what we know, very high rates of fatal injuries and a broad range of injury problems. But to date, what's happened is that because injuries have been hidden among wider health problems, injuries haven't been a high priority. And one of the things that tends to happen when we address Aboriginal health problems is that the community says these are the problems that we want to address. And because injury hasn't been right up there, people are struggling with actually just getting food and a lot of chronic diseases, and I guess suicide's getting up there now. Communities are saying this is a major problem for us, but unintentional injuries particularly haven't really been high on the agenda. So just briefly looking at some of the factors contributing to injury, and I mean this is a context, and I think it's similar to what will happen in Native American populations here. Relates back, it's a long history from our history of colonisation. It does relate back to dispossession of land and the social and economic marginalisation, and then remoteness, hazardous environments, poor access to services, and then all these other things that go along with all of those. Very high rates of unemployment, incarceration, poor social support, low self-esteem, and so on. Again, lower rates of education, lower rates of literacy, higher rates of unemployment. I guess it's a pattern that you probably will be familiar with. Lots of socioeconomic factors that contribute to this, and I'm just going to flick through some of these things. But, I mean, again, it's reasonably well documented. Effects of racism. We still have institutional racism across all of our institutions, and that Aboriginal people will report. High rates of incarceration. We actually have very high rates of Aboriginal people in jail for regulatory driving offences. And again, systems are set up, we have mandatory sentencing in many of the states, and so a very high proportion of people in jail are Aboriginal. Very high numbers of people there for just regulatory driving offences, but because we have mandatory sentencing, end up with very long jail sentences as well. Environmental risks which contribute to injury, so the risks that go along with living in remote communities and the adverse road conditions, and hazardous environments. And then all the sort of things that go along with that, like increased falls risks, and then the at-risk home environments. All the historical and psychosocial factors. I mean, it sounds really depressing. I think one of the things about injury in Aboriginal communities and addressing Aboriginal health is that people will often go, I can't do this, this is too hard, it's too complicated, there's too many things that need to be addressed. And to some degree, there are many factors that contribute to the high rates of injury, but it doesn't mean that they're not insurmountable. There's also inequitable distribution of health resources. Aboriginal people, there is slightly increased spending for Aboriginal people compared to the rest of the population in terms of health services, but given health status, it's a lot lower than what it actually should be. And certainly for injury, there is inadequate intervention levels and very poor understanding about what kind of programs we need, and a certainly need for capacity building in local services. Alcohol has a huge impact. There have been a few studies that have looked at that, but it certainly contributes to high rates of injuries. There have also been some intervention studies that have looked at the impact of alcohol. There's certainly been studies that have shown that community-led alcohol bans in communities are effective at reducing the rates of injury. So there is some hope there, but it needs to be community-led interventions. There are many risk factors, many of them related to disadvantage, particularly by location, and many of those things can actually be addressed by programs that address disadvantage. So they don't need to be specific Indigenous programs, particularly for road injury. So for road injury, governments are trying to invest in better roads and better prevention programs in remote areas, so it is very challenging. And those things will impact on Aboriginal people and injury and better access to care. What we do know, though, is that Aboriginal programs need to be led by Aboriginal people. So what best practice is having capacity building processes through government, community and research, but that involves Aboriginal people, that involves Aboriginal leadership. It means embracing Aboriginal perspectives on health and injury. We know very much from public, a lot of research that's been done with Aboriginal communities and led by Aboriginal people is that the programs that work best are ones that come from grassroots, that are led by Aboriginal people and are done by the community, for the community, but with sustained funding that exists sort of from 5 to 10 years. As in many, this is just not the case in injury, but we're very familiar with this story in injury, which is that we don't have sustained funding models for implementation and evaluation, particularly for injury programs, though, but it cuts across many Aboriginal health areas. History of poorly funded grassroots programs. So grassroots programs will pop up from the community. Someone comes up with a great idea, it works really effectively, but then whatever small grant that community's got or that effective person in that community gets burnt out and the whole thing collapses and we have to start all over again. And of course, there's never been an evaluation done, so there's never any rationale for sort of more support. So we do have significant gaps. What we're working on now is actually trying to close some of those gaps. So I'm just going to briefly, before I finish up, just tell you about some of the programs that we've got going in injury. We are the only Aboriginal injury research group in Australia, so we're building a sort of reasonable program of research now to try and address some of these. It's been a very slow growth, and we do this in partnership with the Aboriginal communities that we work with, and we have Aboriginal people involved at every level of the program. Now, it's really important that we do that because for me as a non-Aboriginal person, can't be running a program addressing Aboriginal injury without actually having very, very strong involvement. We've got a very strong capacity building program, so we're employing Aboriginal staff across all of our programs and supporting them in terms of master's degrees. We will looking for PhD students as well, and even when we have funding, we have difficulty actually finding students, so we're coming back to training people at the master's levels and growing researchers in that way. I've got studies looking at road safety and driver licensing. So we're just finishing off a big study where we've done a community survey of Aboriginal people attending medical services to look at driver licensing, road safety and road safety. We had something like 700 people across 4 sites in New South Wales and South Australia, and really that was an observational study, and we sort of supplemented that with qualitative work with stakeholders in the community and policymakers to look at perceptions of road safety, but also what services were available for prevention of road injury in those communities, and also driver licensing. That then has led to Driving Change, this second study, which is, in fact, it's not actually addressing road safety. So all the work on road safety that we've done has actually, and licensing has shown that driver licensing is the biggest issue that the community is actually finding, and that doesn't relate to the prevention of road deaths, actually relates to keeping people out of jail and getting them jobs, which is seen as a more important issue for the community. we've got a very strong graduated driver licensing system in all states of Australia, but what that has now meant is that people from disadvantaged groups are finding it very hard to actually get driver licences. For Aboriginal people living in remote areas, most jobs are related, you need a driver licence to get a job. People have got low levels of literacy and have got a lower skill set. So, in fact, having a driver's licence and being able to get employment is critically important. Very high rate, and what the work that we've done, not just in that study, but other work that we've done in more remote communities, has shown very high rates of unlicensed driving, and that's linked to sort of poor employment, high rates of jail time. So this study is actually a step wedge licensing support trial. We're working across 12 communities in New South Wales where we're gradually putting in place this program and looking at the impact of it on driver licensing in young Aboriginal people. So that's led by Aboriginal people in each community. There's an Aboriginal staff member who basically runs the program, and that includes helping learner drivers get supervised driving hours in a car, taking them through debt management processes, helping them go into the vehicle registries and getting their driver's licence. So, and we're getting some great outcomes from that study as we go along. We've got another big program, Buckle Up Safely, which is a child restraint program, which is being rolled out in another step wedge trial in the same 12 communities, and it's similar. An Aboriginal staff member basically delivering and training people in the local community about child restraints and giving subsidised restraints and fitting of child restraints in the community. We've got a couple of other big cohort studies. Archer Study is an adolescent cohort study, and the Drive is a very large study of 20,000 novice drivers that we've got, and in both those studies we've got a reasonable proportion of Aboriginal people in them that we're sort of looking at the data for. We're doing work in falls in older people. This is, at the moment we're doing audits of existing programs to look at what falls programs are being run for Aboriginal people across New South Wales, and we're going to be developing and adapting existing falls prevention resources and piloting them in community settings. The last study is our burns study, and that's this is actually pretty exciting as well. We working across 4 eastern states in in Australia, and it's the first time anyone's actually done any work on burns in children in Australia, pretty much. We've got a bit of routinely collected data from Western Australia reporting on incidents of burns in children, but no outcome data. So what we're going to be doing is Aboriginal children have got about 4 times the burn rate than the rest of the community, increases with remoteness, high dropout rates from burn care. So what we're doing is following all kids who come to the tertiary burns units and following them for 2 years, collecting information on quality of life and functional outcome, but also looking at their access to the health services and tracking them wherever they come from. It's going to be very challenging because we know already that we're working with kids from very remote communities in Northern Territory and Queensland, and children that live in urban parts of Sydney. So actually the biggest challenge that we've got at the moment is actually developing a set of tools that can be administered consistently across those populations and for families in those settings. We're looking at basically the barriers to care, where people drop out. I mean, you know, when you think about burn care and you think of a child that lives in a very remote community who's got to wear a pressure garment and keep it clean and maintain a reasonable degree of cleanliness in a sort of, you know, desert setting, you can imagine that that's very challenging. So we'll be following that and looking at access to care. We're working with all the burns units, but also with all the Aboriginal community-controlled health organisations and various policymakers on that. We actually had our first meeting last week with the whole team, and we had a big burns policy roundtable with about 30 people from across the country sitting down and talking about it. And that was the first time any of those people have ever spoken to each other. So I don't think any of the burns people have ever talked to any of the Aboriginal health people before, and vice versa. So even at that stage, it's been really exciting just to actually bring people together to start looking at these kind of issues. It's hard to believe that that hasn't happened in the past, but, you know, we're moving forwards. We do have very developing use of telemedicine for these remote communities, and I think that's one of the things that we're going to be looking at in terms of developing models of care, for improving the models of care for burn care in this population. So that's all. This is some of our Aboriginal staff. This is 1, 2, 3, 4, 5, 6 of our staff members who are involved in driving change, which is a licensing program. And this is the vehicle that we've got. I mean, even just looking at them gives you a real sense of the diversity in the population. So these are all people from New South Wales. You know, they're all Aboriginal people. Marley is actually a medical student from North Queensland. She's doing medicine at the University of New South Wales. She's based in Sydney at the moment. She's sort of a 19-year-old girl. She's been doing a bit of research work with us as she goes through medicine. Janine is a single mother with 6 children who has just become a registered driving instructor, and she comes from a very remote community in far western New South Wales, and she herself has, I think, already got something like about 60 or 70 children through their driver licences in her community. That was even before she came onto our program. So, you know, they've got a very very diverse background. Melissa works in Redfern, so she's our very central urban youth worker. Michael's from southern New South Wales, and his mother was actually a minister in the Australian government. So, again, we have it just gives you a real indication of the absolute diversity that we've got in the population. So, thank you very much. This is also Jake. Jake is the manager of the Driving Change program. He's a young Aboriginal man from Central Sydney who's enrolled in his Masters by Research. And again, he's a future leader in Aboriginal health. He's someone who, if he was up here, you know, tells great stories and is really inspirational. And he's the kind of guy that is going to be actually leading our program in the years to come, I think. And he's kind of the future of the work that we're doing. Thanks very much. I'm very happy to have a few questions if you've got any.
Comment. I'm really fascinated by the parallels of everything. The history, the colonization, the forced separation, and then all the risks that follow with alcohol. And that everything just seems so parallel to what we have here. I find that just really amazing.
Do you have anything equivalent to our Indian Health Service that focuses specifically on Aboriginal?
Yeah, we do. In every state we have these community-controlled Aboriginal health services, and they basically sprang up from the community. The Aboriginal community said, we want our own health service. So before that, people were just accessing mainstream health services. We certainly don't have anything like the Indian Health Service, but we have these community-controlled health services, and they run across the whole country. And so they're quite a formidable group of organisations. So they're organised by state. They all get, I think, federal funding. So some of them they have a variety of different funding streams, but they're supported by government largely. And some of them will take Medicare payments. Others get block funding under whatever grant. But they're community controlled. So they're run by Aboriginal controlled boards, and they deliver a range of primary health care services. We don't have Aboriginal hospitals. What tends to happen is that people go for primary care to these community-controlled health services. They also they do a really good job of it. So they also run healthy ageing programs. They run men's groups. They run child health programs, and they do a whole lot of preventative care as well. For tertiary care, people go to hospitals, and that's, I think, where we have real issues, because our support services for people who are attending hospitals really aren't that great. So I think that's something that I think we struggle with. But certainly the community-controlled health services are very, very strong.
I'm wondering about your Torres Strait Islanders, who are probably a very, very small proportion of your total sample. Yep. Are you dealing with Torres Strait Islanders on the mainland, or is there any work done in the Torres Strait Islanders?
Yeah, there is work done there, yeah.
Because I imagine that, the history of colonialism there is very, very different than it is on the mainland. And so you might have very different outcomes for Torres Strait Islanders. And even for those in the mainland, they're immigrants rather than people who are living there originally.
They're pretty close. It's pretty close to the Australian mainland, and most of the health issues are actually pretty similar. There's a lot of Torres Strait Islanders that live on the north of Queensland, so right up on Cape York. There's a lot of Torres Strait Islanders now that sort of live there, but actually a lot of the issues are very similar, because most of the people that are living on the islands are actually only a ferry ride or a very short plane ride away, so a lot of their health issues are very similar. I think culturally they might maintain more integrity than some of the people who, in terms of colonisation, they're probably more... they've retained more of their community than some of the other locations, but no more than some of those other very remote Aboriginal populations.
A couple questions. You mentioned that at least one politician who was Aboriginal herself. Is there proportional representation in the government of people who are Aboriginal?
No. I mean, look, I think there's a growing number in the Northern Territory that have been in their state government in the Northern Territory, and each of the state governments do have some Aboriginal people. And there's certainly Aboriginal representation at the highest levels of government. I'm just trying to think of I mean, probably there is proportional representation because there's not that many politicians and they're only 2.3% of the population. So off the top of my head, I'd imagine that it's probably not too bad. There's certainly been a push to include support Aboriginal politicians. But again, I mean, we've just had a big coup in the Northern Territory because there's 3 of the Indigenous members have actually just resigned from the government and gone over to a breakaway party because the Conservative government that's in power that they've been aligned with isn't representing their constituents. So it's always a bit of to and fro there.
We hear a lot about, this is silly, but I hear a lot about how many poisonous creatures there are living in Australia.
About what?
How many poisonous, spiders and snakes and lizards. It doesn't really seem to be impacting the rates of...
Oh, God, no. No, that's a bit of a furphy, really. Though I must say, when I was in Katherine, I was on my early morning walk, we saw a saltwater crocodile in the river, and there've never been saltwater crocodiles there because there've been so many floods lately. The saltwater crocodiles have come down from the sea. There's something quite disconcerting about looking down and going, oh my God. But no, I mean, really, they're pretty safe. So you're okay to travel there.
Yeah, a tour guide there told me that a lot more people were killed by falling coconuts in Australia than by crocodiles or
yeah, that could be true.
the other snakes.
Road deaths. I mean, you're most likely to be killed in a car crash than anything else. Most likely. That is probably your highest risk anywhere you go. So, yeah.
And not everybody has guns like here, so.
No, we certainly don't have a gun culture, so something we're working very hard to preserve our sort of non-gun culture. Anyway, thank you.